Hello there, Tony Meekum. This is topic 8, the well-defined radiopaque or mixed lesions with no radiolucent rims. So why do I specify no radiolucent rims? Well, because the next lecture is going to be with radiolucent rims. So we'll get to that. And seeing Olaf in the background here dancing around in the sun, that's doing double duty. These lesions are opaque, so bright. They're also benign, happy to just sit there, no treatment at all for the most part. Two exceptions will flag: condensing osteitis, which hopefully you already know how to handle, and extensive fibrous dysplasia. Otherwise, these lesions are all just leave them alone. Get your study guide out and keep your chart handy. So the acronym to measure all these lesions that belong on this differential is TOFIE, to remind you that it's kind of hard, just dense lesions in the jaws with no radiolucent outline. So Tori, Osteoma, Fibrous Dysplasia, Idiopathic osteosclerosis, which we've already covered, and hyperostosis, exostosis for the E. But I'm going to go ahead and cover that right at first, because these are all just kind of variations of the same thing, proliferation of dense bone. I would think of this similar with it as well. And so let's get on to tori. First of all, the palatal torus, or Torus palatinus, is a bony protuberance in the midline of the hard palate. You may have seen this before, maybe you have one, maybe you know someone that does, and 1 of 5 patients have it, so you're going to see these if you haven't yet. And really all it is like it sounds, just a projection of bone. In most cases, it's very dense. All of these tori are, as well as most of the things that we're going to talk about in this lecture. So homogeneously radiopaque. And there really is no treatment for it unless someone needs a denture. A prosthesis in that case might require to remove it surgically. So here are some examples. Black and white image, but here you can see the palatal torus right in the midline. Here's what it looks like in a panoramic. This is a cropped pano. Nice and well-defined and smooth. There's no real internal component to it. There's no real cortex to it because it's all dense bone. It's all compact bone. And here's what it looks like in some intraoral radiographs. So be able to recognize these. And these are going to look really similar to the exostoses we're going to talk about in a minute too. So all of these are just dense bone. Same with osteoma, just kind of proliferation of dense bone. But knowing the location of this is what tells you, oh yeah, that's just the prototypical location for it, the Torus palatinus. A couple more examples, more of an occlusal radiograph. Here we can see the palatal torus in a coronal CBCT. And so you'll see this a lot, but again, it's no big deal, no treatment needed. Same with mandibular torus. So maybe you've had a hard time taking radiographs on patients that have mandibular tori like this. This is a little less common than your maxillary tori. Only 8% of the population. Sometimes I feel like it's more than that. I guess, of course, it depends on your population type. And what is this going to look like radiographically? Well, just the same as the maxillary torus, right? Except now it's on the mandible. This smooth, well-defined, mostly homogeneous outlines. This one to me looks like it could be an exostosis. So sometimes you have to verify that with the patient in the mouth. Here's an axial from a cone beam CT, axial slice. Well-defined, smooth borders. In this case, it's asymmetric. We talk about asymmetry being bad, but there are some exceptions to that. Sinuses can grow asymmetric. These tori can somewhat grow asymmetric. Exostoses, which we'll talk about next. And here it is. Hyperostosis is a synonym for exostosis, and this is just a hyperplasia of bone occurring on the outer surface. The most common place is going to be the posterior maxilla. You'll see that a lot. This is a more rare one, but it's extensive all throughout the maxilla and the mandible. But I feel like the posterior maxilla by far is the most common, and sometimes you'll see it around the posterior mandible. You can also have lingual exostoses, as we can see in this coronal, nice big palatal torus. But there's a palatal exostosis, just like we saw with the buccal exostosis. What does it look like in periapical radiograph? Just like the other things, it's just the location. So just like the tori, but the location is a little bit different. So if I saw this, I would say it's likely going to be a buccal exostosis, though I can't tell necessarily that it's not a palatal exostosis. This one as well. What are we seeing over here? We're seeing some proliferation of bone right on the alveolar crest. And this one particularly, it's right underneath the pontics of a bridge. We call it subpontic hyperostosis. It's caused by pressure exerted by chewing on that bridge, and then the two pontics kind of get pressed together. How does bone respond to pressure? It creates more bone, and so that builds up. So that's something you might see, that subpontic hyperostosis. And here's an example of a patient. I've never seen someone with this degree of palatal exostoses, and it's touching his palatine torus. Osteoma is going to be pretty similar, but this can occur anywhere. And so the tori, we had specific locations for it. We have kind of common locations for exostoses around the gums, around the gingiva of the mouth. But osteomas can occur anywhere, and actually they're kind of common in the paranasal sinuses, especially the frontal sinus And then the ethmoid, the sphenoid, it's less common in the maxillary sinuses, so we won't see it with our typical imaging that much, but you will see it a lot with cone beam CT imaging. I feel like in the ethmoid air cells, you can see these little small osteomas, or in the frontal sinuses as well. And here's kind of a rare example, just if you're not sure what you're looking at here, this is a lateral oblique view of the mandible of an edentulous patient. So it's like the x-ray comes from below and the sensor is over here on the side of his face. And so you're seeing the inferior border of the mandibular body, and it looks just like one of those exostoses, doesn't it? Nice and smooth bordered. And these do vary. A lot of them are compact like this, where it just looks just like a torus, just in a different location. But some of them are combined, where it has a bit of a marrow space. And so the cortical ones, they'll call compact osteoma. That's most of them. And then the ones that look like they have a marrow space, we'll call cancellous osteoma, or maybe a combination of the two. Just like all these other exostoses, hyperostoses, it should be well defined and round, usually uniformly radiopaque, although, as we just said, there may be some combination of radiolucency with it. If you saw this patient, it would feel just like it looks. You'd expect kind of a hard, bony swelling. And here's the more common location in the frontal sinuses. How do we know this is not more significant pathology? Well, look at the outlines of the sinuses, and they're still intact. There's still air in the sinuses. This could be a problem if it affects drainage. Then it could lead to sinusitis. But in most cases, these can just be left alone if the patient is asymptomatic. So this was our PA ceph, and then the lateral ceph showing the same patient. Another osteoma, and when we get to the soft tissue calcifications lecture, you might think this is a soft tissue calcification, but this was attached to the lingual surface of the mandible, just this very dense overgrowth of bone. This was just an osteoma, so similar thing here in the inferior border of the mandible. And then if you can get a 3D view, here's the axial slice, and you can tell that this is something that's just growing off the lingual border of the mandible. And it just looks like cancellous bone. That's kind of what tells you that it's an osteoma. Here's another one. This is more what they tend to look like, more smooth, maybe not quite as pedunculated as this one appears. There's another variation on the mandibular ramus. So I feel like these are pretty easy to identify. They're pretty unique in the way that they look. So what belongs on the differential when you suspect an osteoma? Well, consider hyperostosis, the things we just talked about. Is it just a lingual torus? Is it a palatine torus? Or an exostosis of bone around the jaw? Or is it in a different place and it's more of an osteoma? Then when we to the TMJ lecture, we'll talk about osteochondroma as the most common benign tumor, and those can look really similar to an osteoma. Maybe it would look more similar to a mixed osteoma, as these tend to have a mixed appearance. Then if it's in the sinus, you suspect osteoma. Usually it's nice and uniformly opaque. And angioliths typically don't attach to the bone. And so that's a big difference there. Management, these don't necessarily require treatment. Just like with all these hyperostoses, you can think of this as another variation of hyperostosis. But if it interferes with function or for cosmetic purposes, they can be removed. But these are not a true tumor. It's just a overgrowth of normally arranged tissue. All right, let's get to the F of our TOFIE acronym, fibrous dysplasia. This is a big one. This is a good one to know. This is kind of our major fibroosseous lesion. If I were to list the different fibroosseous lesions, I'd be talking about osseous dysplasia, which hopefully you're getting comfortable with now. We talked a lot about osseous dysplasia, ossifying fibroma, but this is the big one. This is the definite fibroosseous lesion. This is when cancellous bone is just replaced by fibrous tissue, which contains abnormal, shorter, more numerous trabeculation. Typically, it's going to be monostotic, meaning just isolated to one bone. You'll see 70 to 85% of cases. But in some cases, it can be polyostotic. And in most cases of those, it's going to be associated with one of these syndromes. Jaffe-Lichtenstein is the polyostotic fibrous dysplasia plus cafe au lait spots. And then McCune-Albright is cafe au lait spots plus endocrine hyperfunction. Classically precocious puberty, and overwhelmingly, if you notice the last point here, it occurs in females. All right, so what would you expect from these lesions here? Well, if this is fibrous dysplasia, it's going to feel like a hard, bony swelling. It's probably had it for a long time. In fact, this stops growing after puberty. In some cases, it can continue to grow with pregnancy or contraceptive use. And so this patient probably knows he has something there, probably knows what it is at this point. Here we can see it extending into the mandible. It's widening the mandible. There's kind of a lot of varying appearance to it. Usually, though, we're going to consider it more of a ground glass appearance. That's your typical fibroosseous. But fibrous dysplasia has, sometimes it even looks somewhat multilocular. And so really the expansion pattern to me is what stands out about this as being fibrous dysplasia. We'll see you more classic examples coming up, but this shows the cafe au lait spots with Jaffe-Lichtenstein syndrome. All right, so one of the classic appearances is filling up the maxillary sinus with a bony type appearance. And just kind of a moderate gray. Maybe you wouldn't describe that as ground glass, but when you've been around pathology long enough and you've seen these fibrous dysplasia lesions that just kind of look this moderate gray appearance, we'll describe that as ground glass. Down here is probably more a typical ground glass, which is the prototypical description of fibrous dysplasia. It does occur more commonly in the maxilla, although it can occur either. As we said, usually unilateral, usually isolated to one bone, and in fact, when it aligns with a suture line, it comes to an abrupt stop. And so if you see it, say the zygomaticomaxillary suture, and it ends right there, and you have a normal zygoma and abnormal maxilla, that's pretty pathognomonic for fibrous dysplasia. Typically, this is going to be ill-defined, though. It's going to blend in with the adjacent bone. You're going to have that granular appearance of bone. But as I said in the last slide, there's a lot of variations to the way it looks. This one looks more cloudy, more maybe that Paget's disease, kind of a mixed appearance. More often, though, you're going to have this generalized moderate gray appearance or the ground glass appearance. One big thing that stands out about fibrous dysplasia, though, is the way that it expands. It kind of expands along the bone. It doesn't look like one solitary cyst or benign tumor that tends to be more ballish in shape and expansion, but it kind of follows the shape of bone, as we see in this case of this occlusal radiograph of the mandible, and it expands outward from there, just gradually expanding. This is showing our ground glass appearance. It also displays that you have a loss of lamina dura, but a lot of lesions can do that. It tends to leave dentition intact, even though it's growing around the teeth. And this is unique. Its ability to displace the inferior alveolar canal superiorly. I used to say that was pathognomonic for it, but a month or two ago, I saw a lesion that did that. That was not fibrous dysplasia. And so most of the time you see inferior alveolar canal displaced superiorly, it's going to be fibrous dysplasia, but not always. All right, I said one of the classic signs is a filling maxillary sinus with this general gray or moderate gray appearance. It looks radiopaque, but it's not as radiopaque as something like compact bone. This was the same image we showed you on the last slide with the expansion and the kind of cloudy appearance. Here it's more cloudy and mixed. As we said, a lot of variation, but in most cases, this is more typical appearance, ground glass. It has kind of thinned and it's changed the cortical bone of the sinus to where now you don't see the cortex anymore. It hasn't really eroded it, but it's changed the bone, and the bone has grown all through here, so you don't have that sinus floor anymore. You've lost the definition of the lamina dura around these teeth. This one looks kind of like a combination of ground glass as well as the patchy. In fact, this may be some hyperostosis on that tooth. So we said typically ill-defined. Think fibrous dysplasia in most cases is ill-defined, but this shows some rare variants where it's well-defined. And in this case right here, I've read some papers on this appearance. Some people refer to this as localized fibrous dysplasia, which may or may not really exist. I think of this as more of a variant of idiopathic osteosclerosis, but it does have that ground glass appearance. I think most of the literature I've read on these type of lesions would consider that more just the idiopathic osteosclerosis. But there are lytic variants as well. As you see this, it almost looks like an ill-defined lytic lesion. But most ill-defined lytic lesions, you're thinking like malignancy, they don't cause expansion of the bone like that. And so that's kind of a unique thing about this appearance. And so they caught this. Maybe they surmised that it was fibrous dysplasia, or maybe they did a biopsy and they just saw these fibroosseous changes. And so they suspected fibrous dysplasia and noted that 18 years later, it started to fill in with more mature radiopaque appearance. The bone's not going to be completely normal, but at least it can kind of calcify in with this fibroosseous matrix. And so these are the different presentations. We say most typically we talk about it as this ground glass ill-defined appearance. That's the classic sign of fibrous dysplasia, but we've shown you a lot of variants. It can appear cotton wool. The famous thing for cotton wool is Paget's disease, but this is really localized to this area, and it shows that expansion pattern of fibrous dysplasia. And then sometimes that ground glass turns into even more of an orange peel appearance. And this is an interesting one. It looks like someone put their thumb on a film and caused a fingerprint image, but that's the actual lesion itself. So it can cause a fingerprint appearance. And then kind of a combination of both, where it's just kind of irregular and mixed. This looks like it may be a similar one to on the last slide where I was talking about being categorized as more of an idiopathic osteosclerosis, but you can have an irregular mixed appearance of fibrous dysplasia. All right, what was the pathognomonic sign here in A? See the superior displacement of the canal? First thing you should think is fibrous dysplasia. All the bone through here, though, it looks ground glass. It's expanding in that fibrous dysplasia pattern. All right, how about image B here? Remember filling up the sinus with that moderate gray. Also the kind of ground glass, or maybe it's more the cotton wool appearance of the maxilla here. All of that is fibrous dysplasia. Here's a rare one, but when it's originating below the canal, maybe think fibrous dysplasia. Most of the lesions we talk about are odontogenic. And so that rules out about 75% of the lesions that we talk about in this course. And so fibrous dysplasia is one that fits here. Doesn't quite look like a Staphny defect because it's more filled in with bone. As we go down here, this one is a little concerning as a possible osteosarcoma, maybe not as destructive as you might see, but very mixed appearance and ill-defined, filling in the sinus with this fibroosseous tissue. That's another sign of fibrous dysplasia. If you see in the 3D view, I think it's a dead giveaway because then all the bone in here, it just has that granular appearance. And it's expanding. Everything about this to me is shouting fibrous dysplasia. A little bit more rare one where it's more lytic, more radiolucent, but again, originating below the canal. Think fibrous dysplasia. Here's that cotton wool appearance one. Here's more of our ground glass, maybe even getting toward that fingerprint appearance. Here's one that filled in the maxillary sinus, but it's really grown extensively from there, even growing down toward the mandible. And so we'll get to systemic things a little later in the course, but that ground glass appearance, when it's generalized, is when you're thinking hyperparathyroidism. So usually more bilateral. With hyperparathyroidism, there's no expansion. Paget disease gives a cotton wool appearance, also usually bilateral, older age group. Fibrous dysplasia, if I didn't mention the age, is pretty young because I said it stops growing after puberty in most cases. Periapical osseous dysplasia, especially if it's florid osseous dysplasia, but that's going to be localized to the periapical region of teeth and in an older patient population. Osteomyelitis, we'll cover more about that one, but look for periosteoreaction, sequestra. Those are the telltale signs of osteomyelitis. Osteosarcoma, think sunburst, sunray appearance. Also look for more destruction, malignant features. There was one that I said looked kind of like an osteosarcoma, but maybe it didn't have enough destruction to be a malignancy. Ossifying fibroma. This is one of our other fibroosseous lesions, and so internally it can look a lot like fibrous dysplasia. Of course, there's variation to both in the type of calcification, the kind of mixed fibroosseous structure internal to it. But the way it grows is really different between those two. Ossifying fibroma is the true tumor, and it grows like a ball. It grows round and out. Typically, it will have a soft tissue capsule around it, so there'll be a radiolucent rim around your ossifying fibroma. That doesn't happen as much in fibrous dysplasia. Expanding concentrically is what we mean by that nice round appearance. Management, it tends to stop growing, as I said. It stabilizes upon skeletal maturation, and sometimes even regresses. And so conservative management is the first option. If it's not causing problems with function or aesthetics, then this is another leave alone lesion. But in rare cases, when it's extensive or aesthetic concerns, or in some cases when it imposes on function, surgical debulking may be required. You'll see cases of this in the skull. In fact, it's kind of common in the skull, and this will grow in and around foramina, nerve canals, and usually it doesn't cause symptoms. Maybe in some rare cases it does. So even in the skull base, they tend to leave this alone. Of course, you want to avoid skull base surgery as much as possible. All right, a few cases to test you. See if you learned anything today. Expansile mass in a 45-year-old woman. This lesion was known to have been present for at least 20 years. What do you think? Is that a normal torus that we started off the lecture with? No, kind of the wrong location and behavior. Is it an infection? You look at this, you see infection? Maybe this being present for 20 years should lead you away from that. She might not be doing too well. She's had an infection that bad that long. But it's been there for 2 decades, slowly expansile, unilateral. This is fibrous dysplasia. All right, you've seen these images before. Hopefully right away you can start recognizing this. Is this condensing osteitis or is it idiopathic osteosclerosis, aka dense bone island? All this is that dense bone island, the idiopathic. So this is the eye from the TOFIE lesion, which we've covered before, so we didn't cover in depth in this lecture. This is an axial slice. You see this well-defined, very dense, almost homogeneous, although there's a little mixture to it. Opacity. All of these are just idiopathic osteosclerosis. Here's a localized hyperdense, although this is somewhat mixed. Idiopathic osteosclerosis sometimes can be a little bit mixed. And you've seen this image before with the resorption of root. Look for the normal PDL space. If you saw a periapical hypodensity or periapical radiolucency, what would you think? You would think, okay, that's more reactive bone to an infection. That would make it condensing osteitis. And this is another one, just a large area of idiopathic osteosclerosis. And is there any radiolucency around these? Any capsule? No, this is just straight radiopacity. So definitely be able to identify idiopathic osteosclerosis and know that term. If I use the term enostosis or dense bone island, I'm talking about the same thing. These are all those. What about in this case? Is this any different or just another idiopathic osteosclerosis? What's different here? We see little radiolucent outlines at the apices. We also see a big carious lesion, missing chunk of the crown here. tells you there's probably infection with this tooth. So that's probably condensing osteitis. And over here, if you just focus on this area, it looks just like a dense bone island, well-defined, normal PDL space. But if you notice that there's radiolucencies associated with tooth 19, then you can probably surmise that this is reactive bone to that infection, and so this is condensing osteitis. Other than that, right there, this looks just like a dense bone island. All right, so remember in our Chico lecture, the acronym Chico for well-defined radiopacities in and around tooth roots. The eco from that was these ones we're talking about: idiopathic osteosclerosis, condensing osteitis, and then the O was for osseous dysplasia. We've talked about those a number of times now. Hopefully you're starting to get comfortable with those. Then what's one thing you can do clinically to test to separate those two? You can do a vitality test. And vitality test tells you if it's a necrotic tooth, probably condensing osteitis or periapical hypodensity, periapical lesion of some sort. If the tooth is vital, then that just rules out your periapical inflammatory lesion. And do you remember what this one is? Looks like it's resorbing the roots of the teeth, but it is more attached to those roots and coming from those roots. There's this radiolucency around it, but it's a little bit thicker radiolucency than PDL space. What was that? Semenoblastoma. This one as well. Kind of the same idea. Resorption of the root, but it's actually attached to the root as it destroys it, coming from the root, and a large radiolucency around it. So these are our semenoblastoma, nice and round, ball-shaped. What's the difference with these? Which one's hypercementosis? Well, that's the one attached to the roots with the PDL space going around it. The enostosis, or dense bone island, idiopathic osteosclerosis, the PDL space is intact and separates the root from the lesion. So idiopathic osteosclerosis, hypercementosis, these should be starting to get easy for you now. All right, so that's TOFIE, the benign, dense, mostly leave them alone lesions, plus the toothy-associated dense callbacks. Recognize them, don't overtreat them, and remember fibrous dysplasia is the one that earns real attention. Next topic, the radiopaque and mixed lesions that do have a radiolucent rim, or the CO5 differential. Sometimes I refer to these because they're opaque with a radiolucent rim as the target lesions. See you on the next one. Thanks.